we won't admit just how long a time we've known each other. So thank you very much for that kind introduction, and thanks for inviting me. So I'm going to try and kind of cover a fairly large scope here, because after really about almost a decade of just sort of sitting around with nothing changing in the dialysis world to speak of, in the past couple of years, there's been a lot of change in dialysis, a lot of new evidence-based medicine, and also some interesting things that we'll get to at the very end. So last year was the 50th birthday of the Bresciamino fistula, so first described in 1966. So it was kind of a landmark year, and we'll come back to that thought in a little bit. But so these are some of the things I want to talk about here this morning. As John mentioned, I'm involved in drug-coated balloons, and by way of disclosure, I am the lutonic AV trial principal investigator and also a consultant for BARD. I'm going to talk about percutaneous fistula creation, which I have absolutely no relationships with, and stent graft applications very briefly, and then just some very interesting sort of medical, legal, and a different term stuff at the very end. So, you know, we have learned over the past couple of years, actually really almost 10 years now, but to get the trial done, but first reported in 2010, that stent grafts in certain applications, at least where they've been tested, are better than angioplasty. It turns out that everywhere a stent graft has actually been tested in dialysis access, it's become superior, it's been proven to be superior to angioplasty. This is from the FLAIR trial. I could show you the same graphs from the revised trial with the Viabond. Pretty much any device that's been looked at has shown this. And so there aren't really any large-scale stent graft versus angioplasty trials in a lot of areas, though, especially in fistulas. So there's the cephalic arch hasn't been studied, the cannulation zones haven't been studied, the inflow, central veins, lots and lots of opportunity for us to still study stent grafts in a randomized fashion. So it's very important for you to understand that the evidence basis right now is really very, very limited applications. Vein graft anastomosis, which is FDA approved, and as I'll get to in a little bit, in-stent bare metal restenosis. So the fluency has gotten itself approved through some sort of back door for anything central to a graft. So theoretically, the fluency is approved for central veins, but that's kind of it's not proven in that fashion. So the only place that's been proven, again, just remember, vein graft anastomosis and in-stent restenosis. And that's important because when we start talking about restenosis and the results of angioplasty, they probably are different in different areas of access, particularly in fistulas, where there may be actually 3 or 4 or maybe even 10 discrete types of lesions that have different pathophysiology and are likely to respond different to the way we treat them. But before we get into that, we want to talk about what makes a good angioplasty, because if we're going to use these new devices, especially these drug-coated balloons, we have to get a good angioplasty first. And this concept of vessel treatment has been out there for a while. But this slide, if you went to cardiology meetings 30 years ago, you would see this slide. This concept is still not all that well known within interventional radiology circles. When you do angioplasty, you get what's called acute gain. Effectively, you blow up the balloon, you stretch the vessel, and you get this enlarged vessel. And you get a certain amount of elastic recoil, which is your net acute gain is how much you blew it up and then how much elastic recoil you got, and then that's your acute gain. And then you get late loss, and that late loss is due to intimal hyperplasia, as you can see. And really, the goal of a drug-coated balloon is to reduce that intimal hyperplasia. The goal of a stent graft is to serve as a barrier to that intimal hyperplasia. And where the stent graft is, that barrier is, but where the stent graft isn't, especially at the ends, then you get that intimal hyperplasia, and that's why you get those candy wrapper restenoses around stent grafts. So again, this is really where the whole drug-coated balloon and eventually drug-coated stent area will evolve, is preventing this spot right here, preventing that from happening. But this does you no good whatsoever unless you do this first. Very, very important concept to understand as we look about how these trials have evolved and are evolving. So if you put a stent graft in, you have that natural barrier right there. Elastic recoil is almost always manageable with angioplasty. So the number of times you'll have to put a stent or stent graft in to treat elastic recoil and dialysis access, in my experience, is less than 1% of the time. Really, all you have to do is prolonged angioplasty. For me, that's a 5-minute angioplasty. It almost always works. So, you know, it turns out actually a couple of studies have actually started and where the patient had to fail acutely on the table. The original wall stent trial in the 90s, the patient had to actually fail on the table. they couldn't enroll anybody because people don't fail angioplasty of dialysis access, as you know. I mean, it works pretty well. So that whole elastic recall business really is not the reason we put stent devices in, but really, and that's why bare metal stents are pretty much dead, and I'll come back to that. And then we get this exuberant restenosis, though, after we treat, and that's what we're trying to do. And so the whole goal of, at least with most of the drug-coated balloons right now, they inhibit smooth muscle cell migration by inhibiting various phases of mitosis. That's what paclitaxel does. And so you're actually stopping the smooth muscle cells from multiplying, but also stopping them from migrating because you mess up the microtubules as well. And that's really what happens in restenosis, as you can see in the little picture right here. Smooth muscle cells migrate in, and then they spew out this collagen-based stuff, which is the intimal hyperplasia. So one of the questions I was asked to answer in a meeting not long ago was, will drug-coated balloons matter? And I think my answer is an emphatic yes. Well, why? Well, first of all, as I mentioned, they won't help elastic recoil, but they should help with restenosis, and they shouldn't leave that candy wrapper effect, although there still may be an edge effect depending on how we do that. I'll come back to that. But the most importantly, a drug-coated balloon avoids leaving metal and plastic behind, and there are downsides to that, which I'll show you. And this is just an example of the drug being painted onto a vessel wall, in this case an artery. And this is that candy wrapper restenosis around, in this case, a Viabond. So if it turns out that a DCB is better than a stent graft, and that study hasn't been done yet, well, I guess you'd use a DCB all the time, right? The only time you'd ever use a stent graft is in this setting of elastic recoil, which I just mentioned is almost unheard of. If a stent graft is better than a DCB, but DCB is better than angioplasty, then there will be a role for both, but you would use the DCB in the setting where stent grafts are undesirable, which there are very, very many. And really, if the DCB isn't any better than angioplasty, and I'll show you that that's not true, it would be difficult to imagine a role, but fortunately that's pretty much gone. But the problem with these metallic devices is, and I'm sure you've all seen this, because at least in my world, we see freestanding centers placing metallic devices, usually bare metal metallic devices, like it's their job. I mean, we sort of joke that if somebody's got a stent in, that means they've been to an outside freestanding access center. And we see this all the time, where they put them in the cannulation zone, and you can see it looks like a bomb went off, where it's been repeatedly punctured here, and this can cause very significant complications. And you can see here that obviously this was done to treat this cannulation site lesion right here, and it didn't work. The patient still has this big cannulation site aneurysm. Pieces can embolize. We've actually seen a piece embolize the heart and the patient almost die. They can get skin erosion, and they get exuberant restenosis, and then they also get infection in those locations. You can also jail future access sites with stents, especially if they're, even if they're well-meaning, especially in the cephalic arch. If you get it wrong, you can make that patient's arm not usable at all, and then there's a cost associated with them. A lot of people sort of look at a patient like this and they say, oh, great, well, let's just lay a stent graft in here. But the problem is, it's really almost impossible to treat this subclavian stenosis without compromising this patent internal jugular vein. And so a lot of people who do stent or stent graft this will end up just stenting right across this and jailing that access site. That's something we should never do. I'm sure you wouldn't do that here, but believe me, I see it in the community all the time. Now, but what about angioplasty? Well, if you get a great angioplasty result, which is we did here, there's really, no reason to do anything for acute gain here. We've got great acute gain, but there still is this issue of late loss. And so if we had the right size drug-coated balloon, would that actually help here? And that's kind of where they go. This is that disaster that happens with terminal arch stents. And again, I'm sure you've seen this, where some well-meaning person decided to stent the terminal arch, in this case with fluency, and you can see that the device goes all the way into the axillary vein. It has resulted in occlusion of the axillary vein. This patient could have gotten grafts and maybe transposed fistula, basilic vein fistula, or whatever in that arm after the cephalic vein fistula failed. But instead now, that arm is no longer usable at all for access for the rest of their life. And this is, this is the problem with terminal arch stents. And this is what we want to avoid. Cannulation zone lesion, as you can see here. Well, for reasons I've just shown you, if you put a stent graft there, that's a problem, right? So we don't want to do that. And this is a great paper. It's not a prospective paper, a retrospective paper, but it actually is really, really solid numbers. Came out of Duke that showed that when they put bare metal stents or stent grafts in the cannulation zone, they had a very, very high infection rate. You can see the numbers right there. And actually, a lot of them actually led to excision of the device. So that's pretty striking, right? You're trying to keep the patient from having surgery, but they get surgery anyway. And they get surgery for infection, which usually means loss of the access. So that's problematic. So that's one of the many reasons we don't want to put these devices in the cannulation zones. And then this is just an example from the literature. RFC showed this, published this patient, and we've seen several patients like this as well, where you can see the stent graft actually eroding through the skin. The patient come in, they've got this little alien sticking up, and they say, Doc, what's this right here? And it's this broken stent graft. Okay, well, it turns out that in the area of DCBs, we've got quite a bit of evidence. So I've been showing people this evidence pyramid for years, and I've always talked about that in radiology in general, the evidence pyramid is on its head because we have a lot more of the sort of level 4, 5, 2, 3 data, and we have very, very little level 1 evidence. Well, it turns out in the world of drug-coated balloons for dialysis access, we actually started with level 1 evidence, which is really kind of interesting. And so I'll briefly review that because I don't want to go into it too much detail, but just to give you a sense of where we stand right now, and this is from like last week on clinicaltrials.gov, if you just you Google or if you just search drug-coated balloon and fistula, this is what you get. And you can see that 2 of these trials are actually closed, including the lutonic AB trial, and all these other trials looking at a whole bunch of different things. They're looking at cutting balloons, they're looking at DCB after cutting balloon, they're looking at DCB before cutting balloon or before high pressure angioplasty, angioplasty, every possible combination you can think of, cephalic arch, that's all being done right now, and they're all randomized trials. Well, that's refreshing, isn't it? That's really great. So these are a couple of trials. These are some retrospective studies, our standard sort of JVIR type paper where they showed in retrospective way that it looked like drug-coated balloons were better than plain old balloon angioplasty, but with all the limitations of retrospective studies. Well, the thing that got me interested in this field was the fact that a couple of investigators, these Far Eastern investigators as well as the Greek investigators, had already done a number of randomized trials with smaller balloons, admittedly, but still with drug-coated balloons and dialysis access. And with one exception, the Singapore trial, every single one of those trials had shown a benefit. And this is really the reason I signed on to be the principal investigator of this trial, because I said, look, this looks like it works. This is a good thing, okay? So these guys, they're all small studies, they're all single-center studies, but they all show the same thing. They all show a benefit of the drug-coated balloon over plain old balloon angioplasty, and some of them really, really dramatic numbers. So this was, I said, this is good, but I was a little bit skeptical because if you think about it, in a drug-coated balloon in the SFA, makes sense, right? It's a single injury model, and then there's healing. There's not a continuing injury, whereas in dialysis access, there's a continuing injury at that angioplasty site. There's still high flow, there's still low shear. All the things that cause restenosis are still there after you do the angioplasty. So why would it work? But for some reason, it does. And just another randomized trial. And actually, the same group now has a randomized trial in PRESS in central veins, same result. Randomized drug-coated balloon versus plain old balloon angioplasty in central veins, better patency in central veins as well. So everywhere we've looked, the drug-coated balloons have really have benefited. So let's talk about the AV trial, the lutonic AV trial. This is a fistula trial. So in the 50 years since the invention of the fistula, there has never been a large-scale, multi-center randomized trial of an intervention to prevent restenosis after angioplasty until this study, which is kind of, if you think about it, that's really remarkable. There have been some graft studies. There were some fistulas in the rescue study of bare metal stent treatment, but really, in terms of looking at a single intervention, there have been studies of treatments at the time of surgery and that sort of thing, but we have not been really in this game in a randomized way. So it's kind of exciting to have this finally a big study in fistulas, and as I'll show you, to actually show some benefit. So this is a multi-center trial. We randomized 285 patients at 23 sites. The primary outcome variable, I'm going to come back to this, is target lesion primary patency at 6 months. And then primary safety endpoint, a typical safety endpoint, 30-day adverse event freedom. And the follow-up is all the way out to 2 years. This study is still ongoing. It's about a year in right now, and so we'll go all the way out to 24 months. The first subject was enrolled in June 2015. It took only 9 months to enroll this study, really a miracle. I give a lot of credit to the investigators and the study team who really got this thing enrolled in record time. The inclusion criteria included, it had to be adults, it had to be a fistula that was working, it couldn't be clotted, it couldn't be in the thigh, they couldn't have central venous stenosis that was symptomatic. They could have non-target lesions. They get one other non-target lesion that had to be successfully treated first, but if that was successfully treated, then they could enroll the other lesion, which had to be the one closest to the anastomosis. You had to successfully treat the lesion before you enrolled the patient. This gets back to that good angioplasty, all right? So you had to actually have a successful angioplasty before you enrolled the patient. So we're not treating the stenosis with the balloon. Very important concept. What we're doing is we're treating the stenosis first, that's the vessel preparation, and then we're painting the lesion with that drug to prevent restenosis. And as you think about drug-coated balloons, got to keep that concept in mind. Otherwise, it's not going to make any sense to you. The diameter is all the way up to 12, so there will be balloons that we can use in some central venous lesions, which is good. That will be off-label for the time being. as I mentioned, they couldn't have a central venous stenosis that was symptomatic. They could have asymptomatic central venous stenosis, and they could have asymptomatic stents in the circuit, but if they had a restenotic stent within the circuit, that was also an exclusion criterion. The lesions enrolled covered all the way from the wrist all the way up to the terminal arch, so really a real-world, everyday, all-comers type study, a U.S. study, so that it's got all the sort of typical types of fistulas that we see in this country. So, as I mentioned, we could have the non-target lesion, but it had to be successfully treated first. As long as they didn't have any residual stenosis, defined as less than 30% stenosis, then they could be enrolled in the study. The one-to-one randomization, and then after successful angioplasty of the treatment site, then the drug-coated balloon applied, and I'll get into the mechanics of that in a little bit, and then the follow-up visit. There were no scheduled ultrasounds, no scheduled fistulograms, different from the FLAIR trial, which some people thought was a mistake that there were scheduled fistulograms. So it's purely clinical follow-up. There was one required visit at 6 months in the Office of Physical Examination, but beyond that, again, no imaging follow-ups, purely clinical. Demographics evenly matched. That peripheral arterial disease difference is not statistically different. As you can see, sort of typical U.S. dialysis population, surprisingly few smokers. I think that's kind of maybe a good trend for the United States for once. And these are the locations, and none of these are statistically different between groups. You can see that we've got about 2/3 upper arm, which again reflects a North American population. In Europe, by the way, 2/3 of the fistulas are in the forearm, so it's kind of different. A very few grafts fistulas at the antecubital fossa, and about 1/3 forearm fistulas. In terms of the actual target lesion locations, you can see that there's a good distribution of types of lesions. So these may all be sort of pathophysiologically different. So it's very interesting to have these, and maybe subset analysis will pull something out of this. I don't know yet, but we can see we've got a good percentage from this terminal arch, inflow, outflow, swing point lesions. Swing point defined in this particular study as that point between the transposed portion of a BVT or a CVT and the non-transposed. So nothing, some people talk about swing point being near the anastomosis. That's not the definition here. It's only an outflow lesion. There was one subclavian vein lesion treated as a protocol deviation, but other than that, you can see the vessels that were treated, again, reflecting a U.S. population, mostly cephalic, but with a third basilic. So we see a lot of BVTs in this country where basilic vein transpositions, and so that's why you've got that 1/3 there. About 1/3 of them were de novo, which again is what you'd expect, and the lesion length actually long. So the lesion length exclusion was 10 centimeters, and actually only 1% of patients were excluded on the basis of lesion length. So again, very, very inclusive study, as you would predict, because we normally can get our lesions treated with a 4-centimeter balloon. Yeah, I mean they averaged 3 centimeters, and you can see very few tandem lesions. So looking at the results then, the primary safety variable or outcome variable was met, and in a highly statistically significant way, and no non-inferiority at 30 days, and you can see that the curves are pretty much superimposed all the way out. These are the results out to 9 months now, and we'll actually be just next week reporting the 12-month results, but out to 9 months, you can see that there is a divergence of the curves beginning at about 60 days, and that is statistically significant pretty much all the way. However, it turns out that we did not meet the primary outcome variable, and because the company chose to use a single 180-day spot definition as opposed to a rolling 30-day, 180-day definition, which I don't know why they did that, but that's what they chose to do. If you look at it with the 30-day, it's significant, but if you look at that point, it's not significant. So you may hear people talking about how the primary endpoint was not met. That is true, but I don't think anybody can argue that these are not different curves. You can see, and they continue to diverge, which is really interesting. And anywhere else you look at it, it's statistically significant. The number of interventions needed to maintain target lesion patency was actually also statistically lower at 9 months. As you can see, about 20-25% lower to get that done. So for this particular study, as I mentioned, it's the first IDE trial in fistulae at 9 months. The results are very encouraging. It is not a panacea. It's something that is a new tool for our armamentarium, but clearly is not going to replace everything else that we do. And I think it's going to have a lot of role in those non-stent areas that we talked about. Some things that we're going to all have to learn, because unless you're in the SFA world all the time, you're not learning about these concepts. So geographic miss means that you painted the drug in the wrong place. And so that people are talking about, putting glow and tell tape on, or there's some marker catheters that are out there, designs on these angioplasty catheters, to try and make sure that you actually put the drug in the right place. And you're also supposed to put the drug at least 5 millimeters on either side of the lesion. And that's hopefully to prevent that candy wrapper effect from happening with the drug. Contact time, the longer is better. So minimum 30 seconds, but up to 2 minutes, you continue to get more drug into the wall. And so a 2-minute angioplasty, I do a minute and a half anyway, so for me that's no change. But when I talk to a lot of people, they're a little bit reticent to go with a longer angioplasty. They're afraid they're going to thrombose the vessel, which just doesn't happen. But I don't know, John, what's your angioplasty, your duration of angioplasty?
For these ones?
For no regular, just plain old angioplasty.
I'm a 1.5.
So you're in the same camp. But you talk to, especially in Europe, you talk to a lot of Europeans, and they're afraid to go any longer than 30 seconds. They're like, oh, I'm going to clot the vessel. You can do a 5-minute angioplasty, you will not clot the vessel. Transit time, the faster you get the drug to the lesion, the better off it is. So it should be, again, should be less than 30 seconds. So we got to be pretty swift. We got to be efficient. You can't sort of sit there with the balloon in the vessel and say, well, maybe I'll move it here, maybe I'll move it there. You got to get in, blow it up. And everything old is new again. A lot of you probably don't even know what is meant by a compliant balloon, especially the younger folks. But back in the day, John and I talked about compliant balloons all the time. A compliant balloon means that when it's at its rated pressure, let's say it's a 12 millimeter balloon, at its rated pressure, it's 12 millimeters. But if you take it up to twice its rated pressure, it gets larger, and the percent compliance reflects how much larger it gets. So these balloons that are being used to deliver the drug, everybody's platform, not just the BARDs, but everybody's, they are compliant balloons. And so you want to make sure, first of all, that they're inflated all the way up to their nominal pressure, which for me is, I haven't used a inflation device in over 10 years, but now I'm going to have to go back to using inflation devices because I have to take it up to at least its nominal pressure. And then you don't want to take it too far beyond because then you're over-dilating and maybe causing more trauma than you need to. So you want to get that Goldilocks inflation or just right at the rated pressure. So will they matter? I think, obviously we haven't tested them against stent grafts, so that's the next test. But we know they're better than angioplasty, so they're clearly going to matter. And as I mentioned, I think in those key areas, those no stent zones, of which there are many, 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 they are definitely the best thing out there right now that we have. And John and I were talking about this last night. He was telling me that he's already using the balloons a lot in an off-label fashion because these, of course, are not approved in the United States yet for this application. They're approved for the SFA. So I'm going to move on. I'm going to completely change gears now to something that's actually very, very exciting. It will be interesting to see where this lands. But right now, you may not be aware, but there are actually 2 different devices. They're actually, one of which is already approved in Europe for the percutaneous creation of AV fistulas. Which, think about it, well, okay, anatomically, the artery and vein run right next to each other. And, I'm sure you've thought about this. I've certainly thought about it for a long time. Why can't we just make a fistula percutaneously? And some brilliant people figured out ways to do exactly that. And really, this really could revolutionize access or not, depending on sort of how well these devices work. And obviously, cost effectiveness is a huge issue as we move forward. So this is the first paper on the TVA device, the ellipsis device. At very, very high success rate, and you can read this paper. Low complication rate. But one thing to understand is that this is a Canadian trial. Okay, so the NEAT trial, this trial, these are all Canadian patients. They're all thin. The Canadians are very used to sort of thin people with small fistulas. Their flow rate requirements are lower, so it doesn't necessarily reflect a U.S. population. But nonetheless, good results. There's the consort diagram, and you can see that in these folks, one of the things they do at the time of the procedure is they actually coil the vein on the way out. And that's actually part and parcel of it because they want to try and consolidate the flow. Why do they want to consolidate the flow? Here's why. It looks like a bomb went off in there if you look at this. I mean, if I did this fistulogram, I'm like, what the heck is going on there? So what they do is they embolize one or more vessels to try and consolidate into a single vessel and try and get it to go superficially as opposed to in the basilic so they don't have to do a transposition. And I'll come back to that concept in a second. But if you look at the success rates for the primary endpoints, they're absolutely, and the secondary endpoints, they're absolutely amazing. So what these devices have in common is both of them create the fistula at the elbow or near the elbow, similar to a grafts fistula. They're both outpatient procedures. They both use local or regional anesthesia. And virtually all these patients need some sort of secondary procedure, either at the time of creation or subsequently, and I'll come back to that. So they differ in different ways. One's like a Bovie, that's the ellipsis device. One's radiofrequency, that's the Everlink, which I misspoke. The last one I showed you is the Everlink. They use different vessels a little bit. They're different. Some are single catheter, some are dual catheters, or one is the other. And one is purely ultrasound guided, and one is ultrasound fluoroscopic guided. So I'm just going to show you these little videos. This is just a quick video. This is the first device, the Canadian device. And as you'll see here, first the device is put into the artery, and then another catheter is put into the vein. And what you're going to see is that these are going to pair up. They pair up with rare earth magnets that stick the two devices together between the vessels, and that allows them to get the perfect lineup to create the AV anastomosis. So just kind of the usual stuff we're very familiar with. It's almost like putting a PICC line in, but backwards. Actually, that's actually one of the challenges. You get valves that you have to go through when you're going on the venous puncture. So again, micropuncture access, ultrasound guided, fluoroscopy. These two axes is created, and then the video runs a little more slowly than I do, but I give you a chance to catch up. So now we're putting the device in. You can see that the target area is just below the elbow, and this is an ulnar to ulnar anastomosis. So we're not compromising any vessels that are normally used for dialysis creation surgically. Now the two things are right here. They're gonna line up. Right now they're not facing each other, but the magnets click together, and then this little foot pad comes down. The pulse is given, burns a hole between the artery and the vein, and miraculously you've got an AV fistula. It's a thing of beauty. There's our fake blood vessels. So anyway, that's the concept, and I think this actually tells the tale. It goes everywhere. So again, you have to kind of control that, and so that's where the embolization. So what they do is they actually, right, as you can see here, they're coiling the brachial vein on the way out to try and get that deep flow superficial. So that is part of the procedure now. And in fact, they're making that part of the procedure too for reimbursement purposes to try and make it, because there's no reimbursement for this right now. So effectively doing this, you get and there's sort of idealized creation of the fistula with enlargement of the veins. All right, so their trial the NEAT trial is complete. Reasonably large study, non-randomized, and again, their primary outcome variable is a functional fistula at 3 months, and a number of secondary outcome variables. As I mentioned, it's CE marked in Europe. There's that picture again, and this is what it looks like clinically. This is Dheeraj Rajan gave me this, and here's there's no scar, right? There's just this fistula that's miraculously there, and you can see the maturation rate pretty darn good, considering that the maturation in a large U.S. trial was only 40%, right? For surgically created fistula, this is actually pretty darn good. But again, caveat, thin patients, Canadians. There you can see the patency, and very important number, at this point, only 0.46 interventions per patient year. That's a very, very important number to remember as I show you the other device. So the other device works really differently. This is also a non-randomized study, but this is a U.S. study at 5 sites. They are actually almost fully enrolled, I'll come to those, but these are the outcome variables. Very, very similar outcome variables for these compared to the NEAT trial. So this is, as of this month, you can see they've got 103 patients enrolled, so they're like 2 patients short of being done. They have pretty much always done a secondary procedure to direct flow. The technical success is very, very high. And the maturation procedures, which they call anticipated, include a lot of things. So a lot of these patients are getting surgery, they're getting transposition, superficialization, because this is an American population, the big arms. They are getting some embolization. But afterwards, because this is done under ultrasound in the office as opposed to being done fluoroscopically, so they really aren't in a position to do the embolization at the same time of the procedure. So will that change? I don't really know. And there's also some cubital vein ligation going on in these patients. The 90-day patency, very similar to the NEAT trial, and you can see the sort of numbers here, very, very good flow numbers. The endpoints met in the majority of patients. A key outcome for me is, are you using the fistula? This is actually a secondary endpoint, but are they? And in fact, as you can see here, that a good number, percentage-wise, 80% are in use. So again, that's much, much better than surgical creation and in a U.S. study. They don't think I have the number here, or maybe I have another slide, but if I don't, but here's the difference. They average 1.54 interventions per patient year to bring the fistula to maturation. So a lot more interventions to get there than with the other device. So that's going to be the point of contention. That's what the reps are going to come talk to you about. My device is better than your device because it takes fewer interventions to maintain success. And just this is a little bit shorter video, but this is showing you how this device works. It's a single puncture. So you start inside the vein and then puncture into the artery. and it's using the perforator to do this as opposed to the ulnar, but you're still going into the ulnar artery. And then the device goes in through a 6-French sheath, as you can see here. This is all done under ultrasound, no fluoroscopic guidance. And then you're going to see the tenting the artery there, sort of traumatizing it. Okay, here's the device. You can see the device has this little gap in it. So that, again, sort of footplate concept, similar to our closure devices, and that's how that comes together. So I'm going to put this in, position it between the artery and the vein using ultrasound to make sure you're in the right spot. Pull it together sooner or later. There it comes. Zap it, RF. And lo and behold, you have a fistula with, again, our artist concept of blood going all over the place. So that's how that works. So who's going to do these? I don't really know. In Europe, it turns out it's mostly surgeons doing them right now. Kind of like endografts, and I mean, you guys do endografts here, but in a lot of places IR docs don't. Kind of like endografts and carotids in the 90s. You know, I don't think we should have necessarily thought that it was a gift to us that we were going to do these when somebody else does them all the time. And I think it's the same thing here. I think that there are going to be a lot of people that get these done in freestanding centers. There are going to be a lot of arms lost. We're going to spend a lot of time doing cleanup procedures in these folks. Whether we do the primary procedures will depend it's all politics. All politics is local, and some places will and some places won't. But it's more to come. Very interesting area right now. Okay, very, very briefly, I want to talk about in-stent restenosis. This is, again, a large randomized trial. This was designed to look at whether a bare metal stent restenosis could be treated successfully with a stent graft better than a balloon angioplasty. You talk about low-hanging fruit. We know the balloon angioplasty is terrible in bare metal stent restenosis, and this should have worked. I mean, of course it worked, but you know, it's remarkable how well it worked. So multi-center trial, and very similar design in terms as the trial I'm looking at right now. This actually has been published. I had these updated, but we couldn't get the slides in this morning. It's published in JVIR last December, and you can see the results. No matter what we look at this was fistulas and grafts, central veins, peripheral veins, and so anywhere somebody had a bare metal stent with restenosis, you used randomized angioplasty versus a stent graft. One of the things that this shows me is that bare metal stents are dead in dialysis access. I mean, if you see people with bare metal stents, the restenosis is throughout the entire stent. It's very, very difficult to treat except with a stent graft. So that means that you spent a bunch of money on the stent, now you're spending a bunch of money on the stent graft, and then you're going to get candy wrapper restenosis there. You know, it's not good. And this is an area where drug-coated balloons probably won't work because the burden is so high, although there is a retrospective study that claims that they do. We'll see. You can see the results here. The numbers are staggering. I'll show you the graphs. You can see the differences here at 6 months, 12 months, 24 months. Here's the survival curve. This is access circuit primary patency. It is statistically different, but not a lot. So we wouldn't expect that, right? Because all you're doing is really looking at the treatment site, you know. So that's not really where we expect to see the big difference. But the big difference is here. You can see much more separation of the curves because, in fact, we're looking at the target lesion here, primary lesion patency. And when you put the stent graft in, you know, I mean, look at this. Angioplasty at 3 months, almost nobody is still working. And, you know, almost more than half of them are out to 6 months. So this is a real benefit. So for me, you know, I don't use stent grafts in every patient. I use them selectively. But for me, when I see bare metal stent restenosis from somebody who had a bare metal stent placed at the outside, it is a no-brainer for me of when I'm going to put a stent graft in. I don't think you necessarily, I mean, the only one that's FDA approved for this is the Fluency, so I think you have to take that with a grain of salt. I think obviously any stent graft can probably do the job here. And this is right now the only study looking at angioplasty versus a stent graft in fistulas. And this was done in the terminal arch. These folks tried to start this study. They tried to do it without any industry influence. And here's what they got for it. They ended up having to stop the trial. They had all kinds of protocol deviations by the investigators. The investigators were cheating all over the place. And the final analysis, in spite of the fact that they only enrolled like 14 patients, look at the difference in the curves. So I suspect that, I mean, the Covera study right now is looking at this in a large multi-center trial. And that study is almost fully enrolled, and I would be shocked if we don't find that stent grafts are also better than angioplasty in fistulas. Everywhere they've been looked at, they're better, including here. So the question then remains, well, okay, when do we start comparing drug-coated balloons to stent grafts? And that's going to be the next battleground, so to speak. So I want to finish up with some stuff that should cause you to wriggle in your seat a little bit. And this is, John mentioned that I've been very interested in appropriateness of angioplasty and avoiding the oculotherapeutic reflex, which is where you see it and treat it. And for almost 20 years, I've been standing on the podium saying that it is completely inappropriate to treat asymptomatic lesions. And this has been, I have to say, validation to see this happen. And the folks to whom this happened, I think it's, you know, they asked for it and they got it. So what happened here? On the behalf of CMS, all of the alphabet soup got involved in a law enforcement approach using the False Claims Act to go after people who were doing angioplasty of asymptomatic lesions. They were bringing people back for routine follow-up fistulograms every 3 months. If they saw a lesion, first of all, they would bill for the fistulogram anyway, which is illegal because that's screening, and then they would also angioplasty regardless of whether the patient was symptomatic with that lesion or not. And in fact, of course, that's also illegal. And so they uncovered what they refer to as creative billing, which I think is interesting. Really a lot has been paid out, including, so this is, you can look on the, you can look on the internet, it's all out there, including right here in your own state of Connecticut, $3.5 million paid out, and these are just a couple of them. There are lots and lots and lots of them. So a lot of people have really gotten stung by this, almost all in freestanding centers. So, okay, that's new. What exactly does it mean? Well, it actually means a lot. So when this came out, and even though, I've never done this, it also affects me. It affects you. It affects anybody who's doing dialysis access interventions, because what it means now is that your level of documentation has to be much, much better than it used to be. So you can't just say, we saw an outflow stenosis and we angioplasted it, because if it turns out you don't have support that outflow stenosis had a clinical indicator that matched it, you've committed fraud. So you have to and I see this all the time. So when I'm looking through our, doing the QA on the QA database, and I see that one of our fellows has written the indication was a pulsatile access, and the patient had an inflow stenosis treated. I say, whoa, that's a mismatch, guys, because inflow stenosis causes an access to be collapsed and not pulsatile. Okay, it has other clinical indicators, but not pulsatility. Pulsatility is an indicator of an outflow lesion. Prolonged bleeding is an indicator of an outflow lesion, right? So you have to match up the clinical indicator. Now, people are already starting to get smart because low flow is inflow and outflow. So now all the freestanding centers say low flow or abnormal physical examination, and that covers the whole variety of sins. But quite frankly, you're still seeing this. I'm sure it's happening here as well, that you're not always matching these things up. You better start doing it. Make sure that you specifically describe the clinical indicator, and it really should be on the request, quite frankly. So we've started to ask them, not just for low flow, but actually the actual number. Our compliance people are telling us that when we say low flow as an indicator, that there should be an actual number from the center. So flow rates less than 400, less than 200, less whatever, not just low flow as an indicator, because the compliance bar has been raised. So, we're all guilty and proven until proven innocent, unfortunately, and this is kind of where we are right now. So if you're not doing this already, I would strongly encourage you to do this. You should never bring a patient back for a follow-up fistulogram. That is, again, unless you're doing it for free. The way to manage this, if you want to be good, is to bring your patients back for an office visit. If they have an abnormal physical examination during the office visit, then you can refer that patient to your practice for the appropriate angioplasty. So that's one way that people are getting around this, to speak. But quite frankly, this is going to result in a lot of unnecessary care not being done anymore, which is great. But unfortunately, it's also going to reduce access to care for some people because, for whatever reason, I think a lot of the dialysis centers who've gotten stung with this are going to back off a lot and maybe undertreat, and that's a shame. But we'll see. But it's the quote that you all said at some point. So to wrap up, happy birthday to the semino fistula. It's kind of interesting that this might also be the end of the semino fistula if they all start getting created percutaneously. And we have a bunch of new approaches to restenosis, and there will be many, many more on the way, which is kind of exciting. And the nice thing about modern evidence-based medicine is that really the FDA insists on randomized trials for all these techniques. And so we're able to get much more robust data than we've been able to in the past. And as I mentioned, the compliance bar has been raised. Thanks so much for your attention.